Well, good morning, everybody. Welcome to pediatric surgeries, pediatric/surgery, not pediatric surgery, pediatric/surgery grand rounds. It's great to see this many people here. Mike and I were just sitting here talking how nice it is to have a room full of people to participate in grand rounds. It's not like this every week, and it was never like this when it was surgery by itself. So I remember giving surgery grand rounds when I first got here. Like, there were about 6 people, and there was all of the pediatric surgeons, and that was basically it. So thank you for everybody for being here. This morning we have Tara Karamlou is going to give us her talk on single ventricles. Just a little bit about Tara. We were able to recruit her about a year ago from University of San Francisco, University of California, San Francisco. Prior to that, she was in Seattle for her pediatric congenital heart training, and during her career, whether I've been through, I guess, Oregon, Michigan, Seattle, UCSF, she developed an interest in outcomes and database, really trying to build databases to answer questions for a rare disease process, which is their entire world, right? I mean, congenital heart surgery, nothing is very common. It's common for them, and it's common in our operating room because we have a very good program, but if you look around the country, it's a pretty rare specialty. I think there's 45 congenital heart surgeons, boarded congenital heart surgeons in the country or something like that. It's about that number, right? So we're really happy that she's here. We're happy for her expertise with regard to the database research she does. She's kind of putting us on the map in terms of recognition around the country. She's in the majority of the multidisciplinary, multi-state consortiums, including a very large consortium in California that she helped put together and build, which is doing very well. So today she's going to be talking about single ventricle physiology, and I'm sure it'll be exciting for everybody in the room as much as single ventricle physiology can be, Tara. So welcome and thank you.
Okay, well, thanks everybody for coming, and I hope that I can keep you all interested for the next hour. There's a big packet, and don't worry, I'm not going to go through all those slides, but I think it's important that you have those for your reference. I have no disclosures. So sometimes I think we all feel like this in the morning. We all want to do really exciting things, but sometimes we have a level of inertia that we have to overcome. So many of you may be wondering why I chose the theme today, which is Through the Looking Glass, a perspective on managing single ventricle physiology patients. And by way of answering that question, a brief digression. So this here is Charles Lutwidge Dodson, who's shown in this picture. Most of you know him by his pen name, Lewis Carroll. And the most famous of his works was Alice and Her Adventures in Wonderland, and his works are concentrated in the theme of literary nonsense. And what this is, it's a genre of literature that balances elements that make sense with some elements that don't make sense, with the effect of subverting language convention or logical reasoning. So that's not really that unlike the practice of medicine. It's some art and some science. Some of what we do is anecdote and defies all logic, and some of what we do is solidly based in clinical evidence. So the phrase, through the looking glass, is a metaphorical expression that was coined by Carroll in 1871 in his follow-up work to Alice, Through the Looking Glass and What Alice Found There. And what that phrase means is on the strange side, backward, as if looking through a mirror. But an alternate definition is a reference to a classic or historical work that reflects on contemporary experience. So today, our looking glass is to look at historical experiences and integrate those with contemporary knowledge and try to develop optimum strategies for managing our most complex and resource-intensive patients, those with single ventricle physiology. So the agenda, I want to just briefly touch on the scope of the problem, which is huge, as you'll see in a moment. We'll talk about the evolution of care for management of these patients, and I want to focus on 2 lesions, pulmonary atresia with intact septum and hypoplastic left heart syndrome, and I'll show you some cartoons to review the anatomy. And then the challenge is to look at our own looking glass and see, have we really leveraged empiric data to improve care here at Phoenix Children's Hospital? So by way of sort of an anatomic primer, this is pulmonary atresia with intact septum. And what you see here is that the right ventricle is a lot smaller than the left ventricle. And this little tiny thing here is the atretic pulmonary artery that takes blood flow to the lungs. One of the challenges with this particular lesion is that it is a complex heterogeneous anatomic spectrum. What that means is that you can have variable degrees of right ventricular hypoplasia. And all of you are aware that the right-sided valve, the tricuspid valve, is a good marker for the degree of that right ventricular hypoplasia. So because it's complex, it can be managed with really 3 different strategies. One ventricle pathway when the right ventricle is too tiny to support the pulmonary circulation, a 1.5 ventricle strategy where the right ventricle can actually do some of the work and it actually pumps some blood through this pulmonary artery, or a 2 ventricle pathway where the right ventricle is capable of being recruited fully into the pulmonary circulation. Okay? Pulmonary atresia, intact septum. What about hypoplastic left heart syndrome? I know a lot of people know about this. It's one of the most sort of landmark lesions in our field. In this case, the left ventricle is the hypoplastic ventricle. The right ventricle does the work of the systemic and the pulmonary circulations. And we manage this through a complex neonatal procedure called the Norwood operation, in which the pulmonary artery and the aorta are amalgamated together. And then there's some type of pulmonary blood flow that we apply, either a shunt from one of the systemic arteries off the aorta to the pulmonary artery, or this valved conduit called a Sano, after Shunji Sano, who described this, although he wasn't really the first person to describe it. We then do a Glenn and a Fontan, but we're not going to focus on those. Okay, so 2 lesions, complex physiology. So the scope of the problem in managing these patients was actually addressed by Danford and his colleagues in their 2015 article. And they looked at phys hospitals. It's not important what phys hospitals are. What are important are these couple of numbers. 11,000 admissions over a 9-year period, over 277,000 inpatient days. And this is the bottom line, almost $4 billion. Okay. That's back in 9 years before 2015. So if we were to inflate this to 2018 dollars, we're almost at 2018, the scope of the problem is massive. So what can we do about it? Well, it behooves us, therefore, to try to understand how we can optimize the management of these patients. One of my interests has been looking at institution and surgeon factors that may play important roles in this. But this is complex because, as we all know, what we do is complex every day. Surgeon factors and institution factors can sometimes interact with each other. They can be surrogates for one another. And patient factors and institutional factors are correlated. So luckily, we've got 2 great biostatisticians here, but it's complex statistical modeling. It's not just throw everything into a regression model and boom, out pops a result, and you go write your paper and present it at a meeting. Finally, our own biases actually affect the outcome and affect the treatment strategies that we place onto patients. So what we wanted to do is understand the concept of leveling the playing field, using appropriately weighted risk adjustment to understand outcomes and compare surgeons and institutions. So what we did, and this is back when I was in Toronto, there's a society that's formed by congenital heart surgeons, and they support a fellow for 2 years. And I happened to be fortunate enough to do that fellowship. And we actually looked at this question. We had over 2,421 newborns that we enrolled prospectively from 4 cohorts, okay? 2 of them are here, PAIVS, which I showed you, and Norwood, which is the first stage operation for hypoplastic left heart syndrome. The others are different lesions, and don't worry about them. But suffice it to say, it was a prospective study to try to understand this problem and get very granular data. So what did we do? We did a bunch of things, but the most important on this slide is 2 things. Number one, if you want to compare institutions, you have to understand the concept of neutralization of risk, right? UCSF did things differently than PCH did things. UCSF might have done things worse or better than PCH did things. we need to try to understand, are risk factors applied in each institution equally? Okay, and the answer is they're probably not. So you've got to account for those in the way you model things. Finally, this is very important. We all know about the STS and the O to E ratio. Well, we were really some of the first people to describe that statistical methodology in using and assessing performance as a magnitude of difference between what's predicted and what's actual, okay? So that was important. So experience is the other issue. Experience is not just how many cases you do, it's when you do those cases, your case velocity. If I do 100 cases over 5 years, that's not the same as doing 100 cases over 5 months. So we used a composite domain to understand the concept of experience. So what did we find? Well, this are just 3 of the representative experience domains that I talked about, okay? And what you see here is that for the Norwood operation, surprisingly, none of the institutional or surgeon experience factors fell out. Okay, they weren't influential as regards 1-year mortality. In contrast, look at transposition, which is what we do, babies that have transposition, we actually do something called an arterial switch operation. It's a highly technical operation, and actually all of the experience factors were influential regarding 1-year mortality. So that's an interesting contrast and was somewhat unexpected. So I'm just going to show graphically and to illustrate a couple of points that I think are critical here. What is this? Well, this is something called the risk-adjusted nomogram, okay? And it shows 1-year mortality on the vertical axis as a function of the cases per year increasing on the x-axis. The line is flat for all institutions, and that just illustrates graphically what I showed you in the cross-sectional snapshot, that experience wasn't important in mortality for the Norwood operation. This is another way of depicting it and shows that if you stratify by the highest volume institution, which in this prospective study did 150 Norwoods. 150 Norwoods, that's a lot of Norwoods. That institution didn't do that much better than any of the other institutions in the series, okay? Surprising. What about surgeon? Is surgeon volume important in this multi-institutional study? Well, it really wasn't. Again, you can see here, one of the problems is that the confidence intervals start widening out at about 30 cases because it's hard to analyze these small numbers, okay? So our confidence isn't that great. But again, interesting data. What about the arterial switch operation and transposition? Well, as I showed you, there was a dichotomy here. In transposition, there is a relationship whereupon increasing institutional and surgeon volume actually does decrease mortality, and there's a potential inflection point at 20 cases a year, okay? So the CHSS cohort was very interesting because it circumscribed a broad historical period. And the way we managed transposition used to be by switching the upper chambers of the heart, and then it sort of changed to switching the great artery. So there was a change in management of the way we fixed these patients surgically or treated these patients surgically. So it gave us a unique opportunity to try to understand, was experience motivating outcomes in the atrial switch or the arterial switch operation? And what we found was interesting, that volume outcomes relationship was really confined to the arterial switch operation. And it was because we were capturing the learning curve for this operation. Okay? All right, so these slides are a little bit busy, but I'm going to take you through them because I think, again, these are really important points to understand. This plot shows institutional performance. Again, I showed you the magnitude of difference between how you're doing and how you're supposed to be doing, okay? These are the institutions that enrolled patients in this Norwood cohort, okay? This is 5-year survival. If you're doing really well, you're above the 0 line. If you're not doing so well, you're below the 0 line, okay? Does everybody understand that part of it? And then this is the legend with the number of patients that each institution enrolled. So I want you to now focus on this patient, or this institution right here in red. That's institution 18. And they only treated 43 patients in the Norwood procedure. Contrast that to institution 30, which treated that 155 patients. Institution 18 is performing the best of all the institutions in this series. Institution 30, that had the highest number of patients, is performing about average. Okay? So why is that? How can you treat 43 patients when this institution treats 150 patients and do the best? Well, this slide gives us some insight into what's going on in Institution 18 and what underlines the better results in that institution. Again, this is a risk-adjusted nomogram, so it accounts for all the other risk factors, and it's mortality at 1 year stratified by increasing birth weight. What it shows is that if you're a 2.5 kilogram infant and you undergo a Norwood procedure at Institution 18, you do better than that same 2.5 kilogram infant at any other institution. So Institution 18 knows something about the management of the low birth weight newborn that's a risk factor in all other institutions, but not in Institution 18. Okay? Okay, same graph. We understand this now. This is institutional performance. Again, 0 line. These institutions are doing better than expected. These aren't doing as well as would be expected. So let's look here. Institution 14 is now the institution that's performing the best in its management of pulmonary atresia intact septum. Okay? And it only treated 20 patients. Well, what's the highest institution? Well, that's Institution 24, which treated 41 patients. So let's find Institution 24. Well, they're not doing that well in their management of babies with pulmonary atresia intact septum. The other interesting thing about this slide is where's Institution 18 that did so well in the Norwood procedure? Institution 18 is not doing as well in its management of babies with pulmonary atresia intact septum. Okay? So again, why is that? If volume is not the most important thing in managing babies with pulmonary atresia intact septum, what is? Why is Institution 14 doing so well in this particular lesion? Again, I think that this graph gives us some insight into that. This is a risk-adjusted, something called a competing risks nomogram. Dr. Zainwell knows about this because they use this in ISHLT to describe transplant outcomes. When there are many competing outcomes, you can fall into a couple buckets. You can either die, you can achieve a Fontan, you can achieve a 1.5 ventricle repair, or a 2 ventricle repair, as we talked about. So you have to understand that as these patients transition between the states, at some cross-sectional time point, everybody is at what we call an end state. That's what statisticians like myself call these states, end states. So at 5 years, this shows the prevalence of all of the possible end states for this lesion. Okay, so at 5 years in this institution, a high percentage of patients achieved Fontan, and a high percentage of patients achieved 2 ventricle repair. This line is the 1.5 ventricle patients. And you can see here that death or mortality at 5 years is low across the anatomic spectrum. What I mean by that is that this institution 14 does so well because they follow a balanced morphologic protocol. Patients with tiny RVs are managed with a 1 ventricle pathway. Patients with big RVs are managed with a 2 ventricle pathway. Okay, so it's a morphologically driven protocol, not volumes per se. Okay, what about the other institutions? Well, why don't they do as well? Well, this shows you why. They're not following that morphologic protocol, okay? This is an unbalanced approach to the treatment of pulmonary atresia intact septum, whereupon you're forcing patients down a 2 ventricle pathway. I know some of the cardiologists don't want to hear this because we'd love to have 2 ventricles in a circulation, but it's at a cost, right? A bad 2 ventricle repair is not as good as a really good 1 ventricle repair, okay? So if you are unbalanced, your death rate is higher than if you followed a balanced protocol, okay? So finally, to conclude with this part of the presentation, I want to show you this data, which I thought was also very intriguing. This is the rank order of all of the 6 institutions that enrolled babies in all 4 cohorts, okay? So these were the different lesions, PAIVS, transposition, interrupted arch, and Norwood, okay? That's not what's important. What's important is to understand that the institutions, none of the institutions was ranked number 1 in every lesion, okay? Institution 18, recall, did the best in the Norwood operation, but they didn't do so well in their management of other single ventricle patients and complex patients. So what does that mean? It means that just because you play the piano well doesn't mean that you play the violin equally well, okay? Okay, so let's move on a little bit and talk more about pulmonary atresia intact septums, because it's one of my favorite lesions, and I think it's a great example of building an argument and moving through the looking glass. What I mean by that is it's complex. We don't have a lot of data, but this series of studies I'm going to show you is a good example of building on initial data and asking questions that reflect a greater understanding of the problem. Okay? And so, again, one step at a time. So I showed you this slide. And again, what we did is we looked at this lesion and said, we need to understand this in more detail. So what we did over a 10-year period is enrolled almost 500 newborns with pulmonary atresia intact septum. And what we showed, actually, Dave Ashburn, who was one of the people who passed away in that crash at the University of Michigan, was the person who published this work. And what he showed, again, was that if you follow a morphologically driven protocol, your early survival and your achievement of one of the definitive repair states is optimized. But what we didn't know from this is whether following that same balanced protocol pays dividends in the long run. So do you do better at 20 years if you follow this protocol? Is a Fontan really as good as a two-ventricle repair? That was the question that we wanted to ask. Okay, so this is data that we published and presented at the AATS. So of course the study has some bias. It's a study of repaired survivors, so take it for what it is. Obviously you're not going to exercise patients who aren't alive. It was a prospective evaluation of repaired survivors, and we did protocolized bicycle ergometry, which is a way to exercise patients and see what their aerobic capacity is. And then we administered a bunch of questionnaires to look at something called functional health status. Well, what is functional health status? I mean, that's sort of nebulous. What it is how patients perceive that they're doing. So things like the PEDS quality of life inventory. Many of you probably use those and know about that. We actually used 3 different questionnaires in this study. But before I talk about the study and the results of the study, I want to illustrate why this is important. So this is a case, and most of the people in the Heart Center will probably recall a patient like this. This is a female newborn with pulmonary atresia intact septum. And she's kind of in the gray zone. She's got borderline right ventricular hypoplasia, but nothing that precludes any of the 3 pathways that we talked about in the beginning. So the question is, if you were confronted with this sort of borderline pulmonary atresia patient, how would you manage them? So just think about that case while we go through the data. So what were the characteristics? As I mentioned, it was a survivorship cohort. As you can imagine, most of the patients with 2 ventricles had better morphology, and so they formed the majority of the cohort. So how did they feel? Again, what's their perceived functional health status? Well, I think this data is really critical, and I tell families this when they ask me, how is my child going to do at 20 years? How are they going to feel at 20 years? Are they going to be normal? So what this is physical functioning. So the normals, the age and gender match norms are here, and not surprisingly, physical functioning is impaired in these patients, okay? Not hugely impaired, but it's impaired compared to normals. But this is what I think is very interesting. If you look at psychosocial and emotional domains, an important dichotomy is evident, whereupon patients with pulmonary atresia intact septum actually feel like they're doing a lot better than they actually might be doing if you objectively look at them. Okay, so they feel better than their age and gender match norms. I think that's important when we counsel families and patients. Okay, so basically, what's the bottom line for this? We didn't find that tricuspid valve Z-score was necessarily important in predicting late functional health status. But that's just one part of it, okay? We all like objective data. What about exercise capacity? How well can this patient exercise? So this just shows you that obviously the patients with biventricular or 2 ventricles had higher tricuspid valve Z scores, right? Again, we were following this morphologic protocol in this series. So there is a very important relationship between the original, this is the original tricuspid valve Z-score. A baby's born and we do an echo. So their original tricuspid valve Z-score is related to their exercise capacity, and this is at 14 and 20 years. So what this shows is that if you've got, this is initial tricuspid valve Z-score, if you've got a tiny tricuspid valve, your exercise capacity wasn't that good. But if you had a larger tricuspid valve Z-score, you exercised pretty well. However, note that nobody's normal, right? Nobody achieves 100% peak VO2. So what about the different management strategies? Is there a difference between if you force somebody down a marginal 2 ventricle repair, do they do as well as if you put them down a 1 ventricle pathway? This doesn't answer that question per se, but it gives us a little bit of insight into it. What this is, again, shows the initial tricuspid valve Z-score, your peak VO2, so your exercise capacity, okay? For people that aren't in the heart center, this is how well you can exercise. Think of it that way. What this shows is that there's a relationship with all strategies. So for all the patients, and this is a little bit surprising for the 1 ventricle patients, the tricuspid valve Z-score does seem to be important in predicting your late exercise capacity. What's really interesting is there's an important interaction, as you might expect, with the 2 ventricle patients. So your tricuspid valve Z-score is more informative in patients who went down a 2 ventricle pathway, and that makes sense because you're using that to provide blood flow to your lungs. So with that data, let's go back to our case of the female newborn. So what all did you guys think? What strategy did you choose? Well, let's fast forward 20 years, okay? That's the beauty of research. You can just fast forward patients. You can't do that in real life. How will she feel? Well, we know she's got worse than normal physical functioning, right? Objectively, she has important physical limitations to what she can do. But she feels that she's doing a lot better despite these important physical limitations. And if you what we call solve the multivariable equation, the best strategy for this patient would have been to put her down a 1.5 ventricle pathway. She would have optimized her exercise capacity, and she would obviously, as we know, what her perceived functional health status would be. Okay? Okay, so we talked about that. So there's a dichotomy. Okay, so I thought this was interesting. This is Alice Liddell, circa 1858. So that's Alice from Alice in Wonderland, and that's actually the daughter of the dean of Lewis Carroll's school, and that was the real-life character upon which the fictional character Alice in Wonderland was constructed. Okay, I just want to mention this study because, again, to finish the story for pulmonary atresia intact septum. What's the next thing? Well, what about fetal tricuspid valve Z-scores? How do we do with those? Now we can do fetal echoes. We've got people like Dr. Lindblad and Dr. McLaughlin doing our fetal echoes. So we're in the process of looking at this in a multi-institutional way to understand whether the fetal tricuspid valve Z-score is informative. And one of the interesting things is whether there's catch-up growth of the right heart structures. Okay, those are 2 unanswered questions. Okay. So that's pulmonary atresia intact septum. So let's go a little bit further down the rabbit hole and look at the next lesion, hypoplastic left heart syndrome, which is arguably more complex than pulmonary atresia intact septum, or as Alice would say, curiouser and curiouser. Okay, so what did this study look at? Well, as I mentioned, we wanted to understand how does treatment evolve, right? Treatment evolves over time. We don't do the same thing every year, year after year after year. We change what we do based on the integration of new data. That's, again, the theme of this talk in moving through our looking glass. So what did we do to understand how treatment evolved for hypoplastic left heart syndrome? Well, this is an administrative database, again, just to change things up a little bit. And what we looked at is all newborns. And we had to use ICD-9 codes, so it's not perfect. But we looked at different management strategies for hypoplastic left heart syndrome, including transplant, including Norwood. But there's other things we can do for patients, right? We can do nothing for patients. Sometimes that's the best strategy, doing nothing for patients. So we looked at that as well. And then we also looked at what happens when a newborn comes to an institution that maybe can't provide some of the strategies that the child needs, so they get transferred somewhere else. So there were 4 options that we looked at in the study. What did we find? Well, this was actually very surprising. Now, granted, this data is a couple years old now, But these are the 4 treatment strategies. So transplant, Zane Wells camp, 2%. Daniel Velez's camp here, the Norwood, 17%. Transfer and comfort care. This was really surprising. 57% of newborns didn't have any surgery at all, okay, during their in-depth hospitalization. Now, you could argue maybe a patient with hypoplastic left heart syndrome got discharged after 30 days. I doubt it, okay, so I think this data is pretty good. These patients did not have a surgical procedure in the newborn period. It's a lot of patients. What was the mortality? Well, it was pretty good in this series, actually. 18% mortality. This is only at 30 days, so take it for what it is. Transplant, 2% mortality. So what was the purpose of this study? Well, what we wanted to understand was how hospitals treat patients. And to do that, we broadly categorized them into interventional hospitals and non-interventional hospitals, okay? So the interventional hospitals were those that did a Norwood or a transplant, and the non-interventional hospitals did neither. They either transferred patients or provided comfort care. So how did treatment evolve over the year sextiles, okay? Well, as you can see, there was an increase in the number of interventional hospitals. So over time, we became more interventional. We started treating more and more patients with hypoplastic left heart syndrome. Okay, but this is interesting, right? It kind of leveled off. It didn't keep going up and up and up and up. Okay, so this, I like this slide because it was a little bit artistic, and I have to thank my biostatistician at Oregon who did this slide for me. What is this? This shows the proportion of newborns managed by each of the 4 strategies. As a function of individual hospitals, and these are confluent histograms that show increasing prevalence of intervention. So these hospitals didn't really do a lot of intervention. They had 100% transfer. You go to this hospital and nothing happens, you get transferred to an interventional hospital, presumably. Hospitals over here, on the other hand, had the highest prevalence of intervention. Some of them did 100% Norwoods, as you would expect. Transplant is shown in pink. What's evident from this slide is that the vast majority of hospitals were really non-interventional hospitals. So they transferred their patients or they provided comfort care to their patients, whereas the minority over here were transplant and Norwood. What is important about this slide is not so much that some hospitals do Norwoods and some don't, right? We know that. What's important here is that it shows our bias as providers and as a specialty. If you come to a hospital that's an interventional hospital, you're going to get a Norwood or a transplant, right? So the old adage that if you go to a carpenter or if you're a hammer or anything looks like a nail or something like that, that's actually true. So if you go to an interventional hospital, you're going to get an intervention, and that's what motivates the treatment of that patient. And I'm not sure that that's the right way to treat these patients. Okay, so basically, clinical management reflects strong institutional biases toward particular management strategies, okay? I didn't talk about this, but for patients or people who are interested in prenatal diagnosis, despite increasing rates of prenatal diagnosis, it didn't really change the number of patients treated with palliation or comfort care. Okay, so quickly a couple more things. So given that we have a limited number of centers that provide the Norwood and transplant, can we increase the number of centers that provide equivalent interventions? Okay, so what I didn't show you, the data I didn't show you, is that interventional hospitals had the highest survival. Well, that's not surprising. If you're going to provide comfort care, your patients aren't going to survive. But is there a way to then, is there another strategy that we can offer patients for centers that might not be able to do a Norwood or might not have as good results with the Norwood? Well, it just so happens that the answer is yes. And so we wanted to look at how the introduction of new technology, i.e. a new surgical therapy, or I shouldn't say surgical for our interventional colleagues here, interventional therapy for these patients, and how does this change the landscape? So what we wanted to do is look at this technology, and this is something called the hybrid procedure. And for people just to understand this, what we do instead of a Norwood, it accomplishes essentially the same physiology with some differences. We constrict the pulmonary arteries to limit blood flow, just like we did with that little sono conduit or with the BT shunt in some centers. And then we put something called a ductal stent here. And a ductal stent is sort of analogous to that pulmonary artery aortic amalgamation that we do during the Norwood operation. This is arguably less difficult technically, and the idea was that potentially centers might be able to utilize this technology and salvage patients when they didn't feel comfortable doing a Norwood. That was the hypothesis anyways. Okay, so we looked at this in the STS. And what we looked at was this, the annualized institutional rate of hybrid utilization. Now that sounds really complicated, but it's not. All it means is we looked at the number of hybrid procedures divided by all other interventional strategies available, okay? And we looked at this and looked at outcomes and how centers adopted new technology and which centers adopted new technology. To do that, we had to make a couple of concessions. Again, some centers, it wasn't universally available yet. So we dichotomized. High hybrid centers were greater than 50%. So these centers utilize the hybrid more than 50% of the time. The low hybrid utilization centers were those that utilized it less than 10% of the time. And we wanted to look at patterns of outcomes in those patients. And I want to just share with you that this study was descriptive, okay? We know it's descriptive. It's not perfect. Nothing is, however. Okay, so what did we show here? Well, this is the distribution of hybrid utilization among all of the centers that report to the STS database. There's about 124 of them. What this shows is that there are 4 sites that did the hybrid exclusively. 100% of the time they did a hybrid. 20 sites were kind of in the middle, and there was 50 sites that never used the hybrid operation, okay? So wide variation. Well, this is where I think the study gets interesting. So this is the percent hybrid utilization. So the amount of time centers use the hybrid, and this was the case volume. This is fairly contemporary, 2010 to 2012. What it shows is an inverse relationship. So if you had high HLHS volume, you rarely use the hybrid. That's interesting, right? So what does that mean in terms of mortality? Well, 30% mortality for the hybrid versus 16% for the Norwood operation. Now, does that mean that the hybrid is worse than the Norwood? Well, no, there's other confounders here. Institutions were triaging babies to the hybrid procedure who were sick, okay? So this is not risk adjusted. This is crude overall mortality. But it is interesting. How about the difference in Norwood mortality by hybrid utilizers, okay? So let's say this is hybrid mortality. And what it shows is that there wasn't a difference. If you use the hybrid procedure, 100% of the time, you didn't do any better than an institution that used the hybrid 2% of the time. Okay, so it wasn't really the type of procedure where it seemed like we were capturing a real learning curve. But maybe we just weren't looking at the right institutions, maybe we didn't have the right data, but that's what the data shows. But this is interesting. What about Norwood mortality by hybrid utilization? Well, there is a difference, and what it shows, I think, is that these institutions were actually moving through their looking glass. These institutions had the foresight, or hindsight, however you want to look at it, to say, we don't do that good with the Norwood. We've got 43% mortality with the Norwood, but if we use the hybrid, we can reduce our mortality to 27%. Now, that's not great. That's 43% compared to 27%, but it's something. So those institutions really are, I think, learning. Okay, so innovation, there's a bunch of phases to innovation, and this was looked at in an essay called The Hype Cycle, and it shows that there's different phases of innovation. There's early adopters in the boom phase, and then there's always a plateau. We always see that, right? The new therapy that comes out is sexy. Everybody wants to use it. It's the coolest thing ever, right? Just like the new toys when you were little. Remember the Cabbage Patch dolls? Probably most of you guys are too young for Cabbage Patch dolls. Those were the coolest thing. Everybody wanted one. But then there's a disillusionment phase. And that phase is when people kind of see the limitations of the technology. Then we move into refinements, and that's that iterative way where you really look critically about how we can utilize this. And finally, there's a niche phase where some of the centers that really should use the technology use it. And I think that's where we are with the hybrid. Okay, so we're almost done. We have about 15 more minutes, and I have about 5 minutes more of data to show you, and then we can probably have some time for questions. So in the beginning of the talk, if you remember the agenda, I know that seems like a long time ago, but we talked about how we're going to apply some of this data to improve outcomes at PCH. So this is an ongoing study that we're sort of in the middle of. We presented some of the preliminary data at the ISHLT this year in April. And what I think we have done here, and again, I say we in the collective sense, but I wasn't here for this. So this reflects the years essentially prior to my tenure here. But what was done here, I think, was very reflective and insightful in that we tried to use all types of management strategies and learn from historical data to improve outcomes here at PCH. And I'm going to show you that I think that we've done that. Okay, so what was this? Well, we looked retrospectively right now at all the patients that were treated. These are only hypoplasts, so not single ventricles that went down in Norwood, only hypoplastic left heart syndrome between an 11-year period. Okay, and we broke this into two eras, not surprisingly, because we wanted to look at evolution of management. And there's a couple of things that happened that I think show this reflective strategy. Number one, based on a multi-institutional trial that was really equivocal, but I think most centers have adopted something called a right ventricle to PA conduit, that sono conduit that I talked about, in lieu of a BT shunt, because the idea is that the physiology may be a little bit more robust with that type of conduit. We also increased use of the hybrid procedure for, quote, marginal patients with Turner syndrome. We actually had a couple of survivors, and if you look at outcomes following the Norwood for Turner syndrome, there's about a 95% mortality. And we were able to salvage at least 2 of these patients. And then we more aggressively utilized transplantation. And this is what this shows. So BT shunt utilization went down from 62 to 22%. RVDPA conduit utilization went up. And hybrid utilization went up, and so did transplant. So we were leveraging all of the types of strategies and applying those in patients tailored to that particular patient. And I think that's the key. And so what happened? Well, in era 1, which is these KM curves, and compared to era 2, we had a 90% 5-year survival rate for babies in the RV to PA conduit pathway. That's 90% at 5-year, which is arguably better than some institutions, I dare say the majority of institutions, 30-day mortality rate for babies with hypoplastic left heart syndrome. So that's pretty remarkable data, and I think it really shows really a emphasis on trying to improve care of these patients, and it has paid dividends. So everybody should be very proud of those data. So that's really all I have to say. I think that we have to continually try to move through this looking glass. I think sometimes it may seem in our specialty that we have not made tremendous headway, but I think if we keep constantly evaluating our outcomes and iteratively improving on what we do and being critical of ourselves and our colleagues, that we can move through the looking glass further and we can actually achieve the perceived impossibles. And I really liked this quote from Lewis Carroll: "If you'll believe in me, I'll believe in you." Is that a bargain? Thank you. Happy to take questions.
So you showed that certain institutions do better with certain operations. So is there a shift in pediatric surgery from pediatric surgery there's a push to regionalize pediatric surgical care into tertiary hospitals? So the TEFs, maybe not the diaphragms because they're too fragile to move, but complex pediatric surgery care, should that be done at a tertiary hospital, not someplace else? Does any of this data, well, maybe that's not fair to say, is there any movement in cardiac surgery, congenital cardiac surgery for that same thing? So that institution 18 that does so well in one disease process compared to institution 13, which did better than the other, is there any sense that that should be happening? Because generally speaking, these babies can be stabilized and transferred, right, as compared to, for us, like if I have a hernia, that's not really an option lots of times.
Yeah, Yeah, I think that's very important, and actually, that's sort of the next phase of this, and unfortunately, we're presenting that very data at one of our meetings, and so that data is embargoed. So while I wanted to show it, you'll have to tune in January to the STS meeting if you want to see it, but absolutely, I think there is real benefits to regionalization, but I think probably the better way to approach that problem is by collaboration and by some type of performance feedback. And that's what this congenital consortium that Dr. Osley mentioned when he introduced me is all about. So rather than closing hospitals, which is definitely an option, and we've gone through some different simulation algorithms in the country to show what that would look like based on closing hospitals according to volume thresholds or according to complexity thresholds. But what that does actually is it increases the burden on families. There is an increase in incremental travel distance, but more importantly, every center is good because they're utilizing their resources, but those resources may not be scalable. So that if you take a program who's a 500 case program and all of a sudden now they're getting 500 more patients a year because you've regionalized, is that institution going to be able to leverage their existing resources to provide that same quality? And I think that's an unanswered question, but it's one of the vagaries in, I think, this argument for regionalization. My own bias is that it's always better to try to teach somebody to be better than say, you just can't do it and we're going to move to the next person. But that may not be pragmatic or feasible either. So I think we might have some answers to that question in the next 5 or 6 years. Dan.
Great job, Tara. There's a lot of data
I know.
to talk. We could ask a million questions on each topic, but taking on what Dan mentioned, I think hypoplastic carcinoma as a disease gets oversimplified. Trying to bunch it up on 30 days survival, certain quality, this and that, the other. I can offer perhaps some insight as to why the institution did 100 and whatever cases did not do as well. The resources to take care of, like you were alluding to those 100 and some, it's diluted. So there's actually perhaps less experience of a person handling that patient population, whereas the one institution 18 is very focused. I think also the introduction of biases of the team. Like you have teams that have been integrated, you're clear within the same feelings of or schools of thoughts of the trainees and whatnot. You sort of take one-sided, and you don't do the same thing that you showed in the last study, where you actually have a narrow strategy using objective data to choose one way or the other. One other thing is that we also have pressures from ranking entities. I'll give you an example. We may choose a very difficult patient to go the pathway of hybrid in planning for a transplant later. This is not going to be a good motorway candidate, but we get dinged at 1 year survival for not making it on that patient. So there's a lot of stuff into play here that, yes, it makes a great paper and discussion, but it's so much deeper than we see really considered. Now, one practical question that I want to share ask for is training. It is hard to relinquish, let's say, a very technical operation to do half of it, a quarter of it from the other side of the table, et cetera. But I think we've come to an operations credit service with an algorithm of, this is how I'm going to see it, and how do we go about the variations. And I think that's where experience comes in. What do you think is the actually optimal essentially pathway to get a junior person from the driver's seat to run solar?
Yeah, that's a great question, and I think having the experience that you have, you may be in a better position to answer that question. But my own thought would be that's the question.
Great. We'll come next month.
Yeah.
I'll tell you why I have to answer the question.
But I think that number one, there has to be some type of graded increase in responsibility, and I think it also, and we've talked about this in the operating room, assessing somebody's commitment to that patient and their understanding of contingency plans. So I think one of the things we all worry about, well, if I relinquish this, is something really bad going to happen? Because let's face it, I mean, you're going to be watching stitches of whoever you're, mentoring or whatnot, so you're going to have them put the stitches in the right place. The question is are they going to do something that's really going to harm the patient? So I think assessing what somebody's contingency plans are at the scrub sink or the day before, what happens if this happens? What would you do? How would you approach this? Let's say we find a crossing coronary. I think at least that assesses sort of their mental understanding of different things that might happen. And I think the final thing is trust, right? We all know that when my son was learning to drive a couple years ago now. And, relinquishing the wheel, even in a parking lot, was like, oh my God. But you have to trust and really care about the person that you're training. And I think if trust and care are not part of that algorithm, it'd probably be a difficult thing to see through. That's my own bias.
So next month who's Tom going to be? So Tom is going to give grand rounds for surgery next month. I'm not even going to pitch out, I apologize. But his K award is all about outcomes in cleft lip and palate. And one of the things he does is he goes around and videotapes plastic surgeons doing a cleft lip repair and palate repair. And then he follows outcomes, and then he's gotten the plastic surgeons that he's videotaping as part of the study to agree that if their outcomes are not as good as another center's outcomes, that they will come and watch people operate in that center to try to improve their outcome. I don't want to steal his thunder, but that's kind of the complex operation. You wonder if that's not something you should be thinking about. That cuts you off. Sorry. Andy?
Great talk. So, simply the fact that we're measuring the CDNF in Heisenberg shows that you can't measure something without affecting health. Has anybody gone back and reading the attachment study or your study to see how publishing STS data has changed that, or is anyone doing that now? Has changed the percentage of comfort care, straight transplant? How are we measuring the data effectively?
So you're stealing all of my ideas, but I'm glad that I was a couple steps ahead of you in my IRB. That's exactly what we are doing. So what we wanted to do, and let me give you an example. We're not doing it in this study, but that's an excellent idea. What we're doing is trying to understand how the SVR trial is changed the way we do surgery. Because my own sense, and again, I know people are proponents of the RVDK conduit, and I showed compelling data that might be the case. I'm not personally convinced that that's the end-all be-all for Norwood pulmonary artery blood flow source. I think that the VT shunt is a very, very good thing, and we probably ought to revisit going back to it, and it's definitely certainly in the common areas. However, we are looking at whether the results of that trial, now that that trial has been over a couple of years, has it changed patterns, okay, and in which centers? And if those centers change, did it change their Norwood outcomes? And the reason I made that first comment, and again, I don't want to reveal some of the data because it's currently being analyzed, and I don't want to be bad to my co-investigators, but what that data shows is that institutions that change strategies that were kind of in their infancy or immature, it didn't improve their outcomes. If they changed from a VT shunt to an RVDK conduit, they did just as poorly as they were doing before. So I don't know what that says, but it probably says that if you're not doing well with the Norwood, maybe you ought not to be doing the Norwood, rather than let's change how we do the Norwood. That's my understanding so far of the preliminary data, but you're exactly right. Somebody's got to go back and look at, are we really moving through a looking glass? And if so, which institutions are doing it effectively?
Question regarding surgeons who did not have did any refuse the invitation?
Oh, it's not my study. It's Dr. Sitzman's study, and he's a plastic surgeon. And I don't know the details. I just know that that's what his grant, his NIH grant, is focused on, is outcomes in a very complex operation. Not dissimilar to, well, probably not as complex as what these guys do, but in the scope of education and making sure people are being trained the right way, I think it's a really good approach, because it's something in cardiac surgery that one of the things we like to teach cardiac surgeons about is that they have great exposure. They open up the chest and it's just sitting right there. Pediatric surgeons sometimes are standing on their head going to TDL, but it's something where they can videotape the operation themselves and go back and look at, well, where was a mistake made or a potential mistake made. So I think it'd be